Hi, my name is Eric Brostowski, and welcome to another segment of EP on EP. It's a delight for me to bring back one of my good friends and one of the leaders in our field, Dr. Prosh Sanders, who's professor of medicine at the University of Adelaide. And Prosh, welcome to the show.
Thanks, Eric. Thanks for having me.
And no big surprise to you, we're going to talk about a topic that's close to your heart, close to a lot of people's hearts: weight loss and atrial fibrillation. And let's start, if we could, Prash, with your landmark study that you published a number of years ago that alerted to the field to the importance of weight loss in the management of atrial fib. Could you hit some of the highlights of that before we talk about new things?
Yeah, no, great. So, look, that was a study we did early on when I moved to Adelaide, and it was really looking at losing weight, and it was done with the help of the endocrinologist, where they did meal replacements. They got people to lose almost 6 points of BMI over a 15-month period. And what it showed was people's symptoms of AF went away in a large number of people. And then when we did Holter monitoring in these people, they had fewer episodes of atrial fibrillation, and those episodes lasted for a shorter duration of time. Now, we learned a lot of lessons from that. The first lesson is that if you replace people's meals, they don't actually maintain that weight loss over time because no one likes to be on shakes the whole time. And the second thing is that we needed to do it slower in order to enable people to do better in terms of keeping it off. And I think the third point is that there's no thing about weight loss without managing other risk factors. And we've got atrial fibrillation as a kind of multi-system disease where, hypertension, sleep apnea, metabolic syndrome all go hand in hand. And so you really need to be treating each of these factors in order to try and improve outcomes. And so then we've had a series of observational studies which really looked at now working with the person and making small changes over time to improve all risk factors. And that was much more effective for us. And we've been able to show not only that it improves ablation outcome, we've been able to show that it's a graded response. The better control that you have over your risk factors, not just weight, the better control you have over maintaining sinus rhythm over time. And probably the most important one was study reverse AF, which really showed that you could maybe alter the course of disease. So rather than going from the paroxysmal to persistent to permanent AF, which if you didn't manage your risk factors, almost 50% did over a course of 5 years. If you manage your risk factors and lost 10% of weight, you actually 88% went from persistent AF to either paroxysmal or no atrial fibrillation. And so you could actually change that disease process. And so that's probably been the most exciting finding that we've published so far in the clinical side of things.
So let me ask you, I know you've, I'm sure, given a lot of thought to this. It seems like a simple concept: lose weight and you feel better, lose weight and your AFib gets better. But it's not to me because I've tried to think about it ever since your study. It's good health, yes, but what is it specifically that makes the AFib better? What you've looked at all kinds of biologic markers. What do you think is the one thing or combination of things? I mean, that will take a persistent AFib to paroxysmal.
Yeah. So look, the first thing that and we did this in animals. It was actually interesting. We made animals obese. You give them food, they eat, they get fat, and they get AF spontaneously as well. And when we lose weight, the first thing that improves is your pulmonary pressures get better. And it seems that first impulse improves the symptoms that one has. So presumably we have an element of AF and HFpEF that goes together there that gives you that symptoms of shortness of breath and palpitations. And that's a first impulse that gets better. But what we've now seen is that fibrosis goes away. So your inflammatory markers get better, your cellular infiltrates into the tissue get better, and reactive fibrosis goes away. And our concept has changed from the fact that we thought it was replacement fibrosis, as we saw with myocardial infarction, but actually stress like this gives you interstitial fibrosis, which gave you the electrical changes that caused AF. But now when you take away that stress, that fibrosis goes away from the tissue. And so that has been probably one of the exciting things we found in our preclinical laboratories. And so that, I think, is the reason why AF gets better, is we've taken away the substrate that used to create it.
That makes a lot of sense. What about the whole concept of pericardial fat? I mean, have you done any work? If you lose X amount of weight, have you seen a noticeable decrease in pericardial fat?
Yeah, very important question. When you started out, it was fat, something close to your heart. Well, that is close to your heart, right? So,
Yeah, very
um,
close.
so look, in the animals, what's interesting is as you get chronically obese, the pericardial fat increases, and not it just doesn't increase, it infiltrates into the myocardium, into the areas adjacent to it. So you form these inert areas of patchy scar, electrical scar, that is going to be its own substrate. When you lose weight, the volume of pericardial fat reduces, but it takes a lot longer to go down. Okay, and we've seen this both in animals and in the clinic. What we haven't seen fully is that infiltration of fat completely goes away. We've seen improvement, but in the time frame we've studied it, it hasn't disappeared completely. So whether that means there's a residual amount of substrate that we're leaving behind in the obese person, or whether we haven't studied it long enough afterwards, it is still left for debate.
One of the things, after I read your wonderful paper, I tried desperately to get it done in my own clinic. Now we live in Indiana, is one of the I hate to say it, but fatter states. I just without a system like you put into place, I couldn't get it done. I mean, very few of my patients, even though they tried, could lose the amount of weight that you had in your paper required to have an effect. So it brings up this GLP one agonist, and I will say I know there's no hard data, but I'm going to ask you where your thoughts are, and I'm guessing you're working on this. I have had a number of my patients who have gone on that, and they seem to be better, but it's just observational now from my own practice. So where are we now with that, and where do you think we should go?
Yeah, I mean, this has been almost a savior, right? So we've actually started using it in people that we would have normally suggested bariatric surgery to, and we've had some amazing results. I would say I have just over 100 people with AF who have been treated with these drugs now. And one of the interesting things that I see is the disappearance of the AF symptoms take a lot longer on these drugs than what we do in our clinic. But the weight loss is dramatically more, and it's more accelerated than what we get in our slow dietary changes that we occur. Now, the reason I think for that is that we're treating one risk factor here, whereas in our clinic, we're treating all these risk factors together. So we're getting them to exercise more. And so we're actually changing cardiometabolic health altogether. And so the other elements are having an effect on AF as well. Whereas when we tend to put people on these drugs, people tend to forget that you got to keep doing the other things. And so although we see the weight loss, we're not seeing the benefits quite as dramatically. But I think reality in this population, we got to get the weight down somehow. And that's going to be better for them in the long run. And so, when you wait out to 12 months, we're seeing pretty similar results. But it's just the acute results aren't as dramatic early on.
Yeah.
We're
Well,
waiting for data, obviously. I mean, the only data we have so far is what Jeff Goldberger presented both at HRS and then an extended series at AHA last year, actually suggesting that the outcomes after AF ablation are much different in someone who's managed with these drugs. So hopefully more of us can get drugged to run randomized studies to be able to show that outcome in a larger group of people.
yeah, and one of the things I think is fascinating, I remembered reading Jeff's stuff. Um, Here's the thing I want to propose to you. If it's all, and I know you're going to know where I'm headed here, if it's all about the pulmonary veins, who cares? Because if you totally isolate the pulmonary veins and you allow someone to still be obese, if it's all about the pulmonary veins, you should be clear of AFib. So, thoughts on that? Clearly, it's not just always the pulmonary veins, right?
Yeah, so I guess it's complex. I think there are a number of sites that could probably take the same sort of activity. The pulmonary veins happen to be the most sensitive and the first. And so, that's why we're all focused on that. But as the disease progresses, and we see this in persistent AF patients where actually non-pulmonary vein triggers become more important, the scar tissue becomes more important. And so I think there's more disease we're starting to look at. We've moved it so far from that original Michel Hassaguer paper of those selected patients with just bursts of activity from the pulmonary veins to now treating everyone with AF. And so I think we're starting to realize that, and we still, as you know, we haven't learned how to treat persistent AF well yet outside the pulmonary veins, and maybe we can alter some of their lifestyle to try and improve that. And we've certainly seen an improvement in clinical outcomes by doing that.
No, I think that's a really intriguing thought about that. I think that's great. Prash, you've had groundbreaking work for all of us, and we appreciate all you've done for the field. Um, I also appreciate very much for you doing this. Our time zones are very different, and you look snazzy and all awake, and yet I know it's probably early in the morning for you. So thanks so much for joining the show, and thanks for all the important work you've done.
Thanks for having me, Ari.